Thank you very much for the opportunity to be here today. Thank you very much to Health Partners for sponsoring. I'm really delighted to add to this conversation. It was wonderful to hear Jack in his global lens. And I hope I'm a bit of a data person, being from the Heart Foundation. We're very evidence-based. So perhaps I can share some things from the cardiovascular side. So the Heart Foundation, we've been around 50 years. We have a single purpose: to reduce premature death and suffering from heart, stroke and blood vessel disease. And we have 4 goals: around prevention, that's primary prevention and secondary prevention; around treatment and support for people who do have heart disease; around equity, the people with the highest burden of disease, with the most social disadvantage, and our Aboriginal and Torres Strait Islander colleagues; and then research. We fund the best of the best. We don't fund buildings and infrastructure, but we fund wonderful people around the country. So compelling. The data's compelling no matter which way you cut it. Australian heart disease statistics in 2015 reveals that although cardiovascular death rates have been decreasing since the 1970s, it remains a major cause of death and disability across the globe. Indeed, in Australia, it's the leading cause of death, and there's significant variation across Australia. Some regions have death rates that are at least double the national average. And we know this occurs in mostly regional and remote areas, highlighting the particularly poor heart health in some of those people in our regions, and we need to work hard to bring that disparity back into play. Significantly, there's variation between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. They experience double the rate of heart attack, whilst age-standardised death rates due to ischemic heart disease are 2.5 times higher for Aboriginal and Torres Strait Islander people. We know it's a heavy burden in terms of health costs to the community, with a total of 71.8 million prescriptions in 2013-14, and huge amounts paid out in health-related prevalence in hospital. More than 500,000 made procedures in cardiovascular disease were performed in 13-14. This is just a fast map that really just highlights, it's just data back going to from 1969 to 2004, but it just shows a whole range of things that have been happening in cardiovascular disease over many, many years in terms of trying to improve health outcomes. And we've come a long way, and certainly treatments have come a long way, but we've also got this overlaying chronic disease. I'm just going to keep going here. There we are. Thank you. Just going to touch on, this is the World Economic Forum Global Risk Report. This comes out every year. This is the 2016 Global Risk Report, and I'm touching on this in the sort of global perspective, because if we look at the top section of coloured boxes are the top 5 global risks in terms of likelihood, and the second section is in terms of impact. And so if you look back to the left-hand side in 2007, you can see, and they're colour-coded by geopolitical, social, environment, etc. But you can see how it changes year on year depending on the impacts around the world. And it's a great report to look at in terms of understanding what are the key priorities. So you can see chronic disease had a real play there in the top 3 back in 2009 and 2010, and then income disparity in 2012, 13 and 14 in terms of likelihood, and to Jack's point, and then now in 2016, large-scale involuntary migration, lots of weather events, climate change, etc. So I wonder when 2017 is done, whether there'll be a lens around some of these other diseases like Zika, etc. If we move to just some quick graphs around ischemic heart disease. So what we can see back from 2005 to 2014, ischemic heart deaths going down in all ages. So we've got numbers of deaths in red and rates of deaths per 100,000 population in grey. So you can see that's been decreasing over the last decade or so. But if you look at the second graph, hospital separations, look how that's plateauing in the last year or so. So this is new data that's just come out, and it's really showing that that's plateauing. We need to keep a mindful watch on that. I'm just going to take you through a few heat maps here, and they all look the same, so I'll just guide you through the legend. So what they are is it's obviously typical heat map, so the darker the colour, the worse it is, if that makes sense. So very high in terms of the dark red, brown, very high rates in mortality, morbidity and prevalence. And then the lighter shades are obviously less death rate, under 10%. So if we think about the darker boxes, over 50% in terms of prevalence, and the red boxes around 40%. So if we look here around ischemic heart disease, and this is by age and gender, you can see if you look at mortality on the left there, Obviously, as you get older, there's more going to be deaths in the higher age groups. But you can also see the prevalence on the right there for men and women is creeping back into those lower age groups. If we look by location, it's interesting to show because we know there is a difference between major cities and regional and remote areas. So if we look here at mortality and prevalence, you can see that in major cities there's a lower death rate than in some of the regional areas, and you can see the prevalence changes there versus inner regional and more remote locations. We know that ischemic heart disease is impacted by CEFA scores, so there's a social economic disadvantage. And so when we map that again between the lowest and the highest quintile in social disadvantage, we do also know there's an impact in prevalence there as well. So you can see that on the right-hand side. If we look at clinical risk factors, so we're now going to risk factors by age and gender, and I know I'm moving a bit fast, I speak fast and I'm an identical twin, that's how I've always worked, I'm afraid. We both speak doubly fast, I think. Clinical risk factors by age and gender. So you can see here, so the two, in the latest data that's come out, hypertension and cholesterol are the leading major clinical risk factors. So hypertension, high blood pressure, and cholesterol, high levels of blood cholesterol. And what we can see in hypertension in particular is, look at that darkness in the heat maps coming down to those younger age groups. So that really needs some extra attention. And the Heart Foundation's just released its hypertension guidelines. They've only just come out. They've got 2.5 years of work with a large group of people really trying to tackle this more broadly with our medical and health professional colleagues. And cholesterol is interesting. Higher impacts for women and younger age for women as well. So you can see the difference between women and men there, and certainly coming down as low as age between 35 and 44. If we look by location, again, we can see this disparity. So we've got hypertension and cholesterol again, and looking at the difference between major cities and their more rural areas, and you can see the differences there. Smoking, Patty touched on this, and certainly there's been some great inroads into smoking prevalence over huge amounts of work over decades, and Jack was just talking about seeing the plain paper packaging in Australia and the way that we keep it all closed in the retail outlets, and Australia's really led the way in that regard. But we still have work to do. We can see that in actual fact in the young males, there's still a lot of work to do with young males to get that smoking rate even further down. And we know that there's things like tax and mass media that can really help to it. Physical inactivity, again, you can see the differences here, females and males, and again in females between 55 and 64, again, that's a higher prevalence there. So this is some new data and a reasonably easy way to be able to describe it to you, to give it sort of hot off the press. And our thanks to the Heart Foundation and the Australian Health Survey for that. Overweight and obesity. So here we can see again females and males, big problem in both genders obviously, but in the males you can see the really dark heat map coming down again in those younger age groups. It's a really huge problem for us all in Australia, and if we say a BMI of over 25 is overweight and obese is a BMI over 30. Location, again, if we apply the same thing, lifestyle risk factors, smoking, overweight, same sort of thing, difference in cities versus regional areas. You can see the clear differences. Again, if you layer socioeconomic status and you look at those differences across those three risk factors of smoking, obesity and physical inactivity, again you can see those differences between those with the most social disadvantage and those who are less disadvantaged. Heart attack, so heart attack by age and gender. Heart attack in terms of, if we look at the prevalence on the right-hand side, one of the biggest things that we know from the Heart Foundation data and research is that if you have a heart attack and you get to hospital, you get the best of the best treatment and care, straight into the angiography suite, etc. What happens is that people don't make the call, they don't understand the warning signs, and so they don't get themselves to hospital in a timely manner, and time is muscle, then they get damage to the heart and a whole lot of other problems. So we're about getting people to really understand and learning that. So again, you can see some prevalence data here and a bit on mortality and hospitalisation. I realise I'm whizzing through. Last couple of things I just want to point your attention to. Don't worry so much about the script on the right, but again, if we look at the graphs on the left, so again, 2005 to 2014, numbers of deaths, all ages, heart attacks in the top graph, and you can see that that's dropped, but look at the plateau. So this is 2013-14 data, starting to plateau. So we need to watch that and understand why that is and what's happening there. And again, the same in heart attack separations. Same with stroke. If you look at the 2013-14 data, you can see a crossover happening. So again, with stroke, we really need to have some focused attention on that. Heart failure. So heart failure, particularly if people have a secondary event, maybe a first heart attack, they have a second heart attack, they have damaged heart muscle, and therefore the heart's not pumping well enough, and so it struggles to do the work that it would normally do. It can really have a lifetime morbidity and mortality. And so, again, having those front-end changes is really important. But again, look at the data on heart failure. Some of that's going up again. So I'm going to close and join the panel, but I'm just going to close with I'm very unbalanced. I've got my boot that's much higher than my other shoe, so I'm toppling. The WHO 2030 Agenda for Sustainable Development. So I know the World Health Organization have got a summit in Shanghai in November, and really looking at raising the awareness and importance of health promotion as a really transformative strategic approach to deliver on these sustainable development goals that's been signed up to by the World Health Organization. So I think I'll close there and join the panel. Thank you.